Hi, welcome back to our Snapshot series, and this time we are going to focus on chest x-rays. So we will just be looking at different pathologies and different presentations that could come up and that you should be able to spot and know for finals. And this time we won't be describing the x-rays, we will just be focusing on the different signs that you can see. So starting off with our simple pneumothoraxes, we can see three different examples on the screen, and there will be a complete loss of lung markings that will be peripheral to the line of the lung. So you can see in the central image, the line of the lung is outlined by the red arrows, and you can see to the left of that, there are no lung markings. So this is indicative of a collapsed lung, and on the right, you can see that the left lung has more or less completely collapsed. And you can measure this distance, so you can measure the space between the edge of the rib cage and the lung, and that's especially important for management later on. Also assess the tracheal position to see if there's any tension or shift. That brings us nicely on to a tension pneumothorax, where you do have shift of the trachea. So this normally needs urgent treatment, as is a emergency, so is something that could be assessed in an emergency station within OSCEs or finals, and this needs immediate needle decompression followed by a chest drain. So the reason we care about the size is because it can alter the treatment, and that depends on whether they're symptomatic and their background of chronic lung disease. So if we have a look at a heart failure x-ray, we can see that we can assess this with an ABCDE approach. So there's your A, alveolar edema or batwing sign. There's the B, the curly B lines. C, cardiomegaly. D, dilated upper lobe vessels. And E is our pleural effusion. So here we can see two examples of your batwing sign. And then this diagram shows all of the different labelled signs that can help point towards cardiac failure. And finally are pleural effusions. So these can be split into transudate and exudate. So cardiac failure is an example of a transudate pleural effusion, and other causes of a transudate pleural effusion could be nephrotic syndrome or cirrhosis, whereas your exudate pleural effusions tend to be more pneumonia, tuberculosis and mesothelioma. So as we can see, the pleural effusion causes a fluid level, which can be seen as a meniscus. Occasionally, you can also get fluid within the fissures, and I think this was on the previous slide. And the costophrenic angles at the base of both lungs are blunted or completely obscured with a pleural effusion. And now moving on to TB, we can see that the left image is showing the typical consolidation in the right lung apex, and this is typical of a post-primary infection. And it's also very typical to have cavitation in these, as well as other pleural disease. You can also have a primary TB, which would show a patchy consolidation without cavitation, and this can progress into a caseating granuloma known as a GON complex. You can also see hilar lymphadenopathy and pleural effusions in this condition. And the right image shows a really good example of hilar lymphadenopathy around the borders of the heart. TB can also present as miliary TB, and you can have miliary nodules which will be distributed uniformly throughout the lungs. Although miliary TB is rare and holds a very poor prognosis, and it's hematogenous spread of multiple uniform nodules, as I mentioned before. You can also potentially see extrapulmonary TB, although the signs for this would be varied depending on the presentation of the TB and the location of the TB. So cancers can have a widely varied presentation on x-rays, and one of the most obvious presentations is that on the left, which is that of a tumour. So you can see a shadow in the left lung shown by the red arrow, whereas the right image is displaying an example of a mesothelioma. And if you see any of these signs on x-ray, they're going to need close follow-up and referral to the respiratory MDT, and this will include respiratory, oncology and cardiothoracic surgical teams, and these will all be involved in planning the management for these patients. So now we can move on and look at different types of infection within the lung, otherwise called pneumonias, and these will most commonly be seen through a patchy white consolidation throughout the lung. And in fact, there is actually a special sign that we can see on the image on the right, which is your bulging fissure sign. And this refers to a lobar consolidation. We can see on the image in the middle, there's widespread patchy consolidation suggesting a widespread pneumonia, whereas in the image on the right, you can see that it's focused more at the base of the lung, the right lung, and you can see that there's again patchy consolidation. Sadly, we can't get through a series on chest x-rays without talking about COVID. And as you can see, it's quite a distinctive x-ray. It has a very varied clinical presentation and massively varied symptoms depending on the variant and your own reaction to it. Additionally, paediatric patients can present slightly differently to adult patients, which makes it quite a difficult presentation to fully understand. However, the X-ray images are very similar to those of an atypical pneumonia or an organising pneumonia. Given the similarity to pneumonia, the X-ray imaging is actually very limited in sensitivity for corona, and it will often have multilobar involvement and will often be bilateral in presentation. And in fact, something that might put everyone slightly at ease, the current recommendation by a wide number of societies is that X-ray imaging should not be employed as a screening or diagnostic tool for corona, but should be reserved as evaluation of the complications. And when looking at corona on CT, you can often see a ground glass appearance or opacities with airspace consolidation, crazy paving appearance, bronchovascular thickening, and traction bronchiectasis. Another feature that you could see on a chest x-ray is that of pneumoperitoneum, and this could be on an erect chest x-ray, and this will often be due to something like a bowel perforation, although other causes can include pneumothorax or mechanical ventilation, so it's not entirely specific. Now moving on to our signet ring sign. So this is a classical sign seen on CT, and it indicates bronchiectasis, where there's a dilated bronchus and accompanying pulmonary artery branch seen in cross section. So this is indicated by the white arrow here. Moving on to some medical devices that we can see on chest x-ray. Here are two examples of NG tube placement. So x-rays are commonly done to confirm the placement of these tubes, especially as the litmus or acid testing is not always accurate. So on the left, we can see an appropriately placed tube, which is below the left hemidiaphragm in the stomach, whereas on the right, we can see that the NG tube has entered one of the lungs and therefore will have to be removed and replaced. You can also see cardiac devices on chest x-rays. So on this example, we can see they have labelled the aortic and mitral valve, and additionally you can see a cardiac device and the pacing wire that is connected to it. So here are some of the references we used to create this session for you. We hope that you enjoyed it and taking the time to watch it. We hope that it helped. If you've got any questions, please let us know, and we hope to see you again for the next one in our series. Thank you.